Morning, everybody. How's everybody doing?
They're half asleep. They're still sleeping.
Early. Who had call? All right, excellent. I remember those, having call and coming straight in. All right, so today we're going to continue with complex root canal anatomy. This is part 2. What's really down there? You know, when we do our root canals, you know, we open up these teeth, we do our pulpotomy, and we access into the pulp chamber. And the question is, what's really down in these canals? What's going on with the anatomy in these teeth? So let's move forward. The last time we worked on anterior teeth, and we also worked on premolars. Today we're going to work on molars. And molars have a lot of complexity to them. You know, there can be as many as 5 canals, sometimes in rare instances 6 canals. And so you got some molars that have just 1 canal, depending on the type of anatomical configuration on that molar. So let's talk a little bit about molars. We're going to spend some time diving into a lot of anatomical variation that can occur or be present in molars. All right, so we'll start off with maxillary molars. And maxillary molars are probably the most complex type of root canal anatomy to deal with, because we always know that there can be a potential for 4 canals to exist in maxillary molars. So let's look at those. I mean, a lot of times we do these maxillary molars and we think, okay, we found 3 canals, we're good, but a lot of times they do have a 4th canal. And if, like we said earlier in the lecture, the last time we gave the first part of the lecture, if we don't look for that 4th canal, a lot of times we're just not going to find it. So when we're looking at these maxillary molars, how many have 1 canal in the mesial buccal root? And when we look at maxillary first molars, according to Frank Wine's study, 50% of them have 1 canal in the mesial buccal root. So that means you've got another 50% that have a 4th canal or 2 canals in the mesial buccal root. 35% of them have 2 canals with 1 single foramen. And then you've got 15% that have 2 canals with 2 separate foramen. Those are the ones that we're really concerned with, that 15%, because the foramen is separate in those canals. Sometimes if you have the ones that join, you know, if you find that main one, a lot of times you might get away with being able to have some success, a degree of success, because those canals join. And if you find the main canal, the MB1, a lot of times, you know, you may have a little bit of success. Not always, because there's still tissue that's left there. But if you have 2 separate foramen and you miss one of those canals, that tooth is going to fail. It's going to fail. The likelihood of failure is very high. Maxillary second molars. Maxillary second molars, according to Wine's study, 64% of them have 1 canal. But then you've got 21% with 2 canals with a single foramen, and then still 15% that have 2 separate foramen. That's just like maxillary first molars. So that's the 15% that we want to make sure we get. And once again, you don't really find them unless you're really looking for them. So in endodontics, we always assume that all maxillary molars have 4 canals, okay? Until we can prove to ourselves that they only have 3. Now, Wine's study was an older study. That was back in 1969. Since then, there have been some more recent studies that show that the incidence of having a 4th canal or MB2 canal in maxillary molars is actually a little higher than the 50% that Wine quoted. This is a study done in 1990 by Coolidge and Peters in the Journal of Endodontics, and they found some interesting results about mesial buccal roots and MB2 canals. When they went ahead and they instrumented these teeth by hand, these were extracted teeth, and when they instrumented them by hand, they found about 54% of them had an MB2. But then they took those teeth and then they added a burr to try to find the MB2. And when they did that, the percentage increased and went up to 85%, 85.5%. And then they took those, and then when they sectioned those teeth, they sectioned them across, okay? When they did that, that number went up to 95%. So according to this study, 95% of maxillary molars have 2 canals, okay? Some of them are inoperable. Some of them we just can't get any instruments in, you know? So when you look at this, they actually had to section some of those teeth to get that number. But as far as a type 1 configuration, it was 4.8%. Type 2 configuration, remember type 2 is 2 separate apices, it's 49.4%. And then type 3 was a 45.8%. And there's no difference, no significant difference between first and second molars in this study. Okay, so, you know, let me go back. I just wanted to mention, I think I made an error. Type 2 is when they join, and type 3 is 2 separate apices. So you still got 45% that are type 3 with 2 separate apices. All right, so variations in canals of multi-rooted teeth. So multi-rooted teeth can have a wide range of variations within the root canal system. For them to be successful, it's critical to know what's normal. Okay, so what's the normal configuration? And then from there, you can move on and discover some of the possible variations. Okay, but it's important that we know what's considered to be normal. So now we have an idea that, hey, most of these molars, most of these upper molars have 4 canals, and we find them. We find them. We use microscopes, we use ultrasonics, and in endodontics, that's our goal, is to try to find those canals. So we know the incidence is higher than what we've been led to believe when you compare it to Frank Wine's study back in 1969. So we find a lot of variation. This is a maxillary first molar with 5 canals. This one had 2 distal buccal canals, which is really rare. You just don't see that often. But when you look at it, it just looks like a regular maxillary molar. But then when you take a look down in here, you see this has 2 mesial buccal canals. It's got 2 distal buccal canals, and it also has a palatal canal. So this is once again, you don't see 2 distal buccal canals that often, and they had separate apices on the distal buccals. So, you know, once again, that's something that's rare. But this wasn't something that we assumed that they had, but we just kind of discovered it from really doing a good thorough inspection of the pulpal floor while treating this tooth. And when we inspect that pulpal floor using our microscope, sometimes we find these extra canals. So we're spending the time looking for those. And here's where we have our working length film, our master cone shot, just to see where we are. And here you can see 5 gutta percha points. And for the final obturation, we got different angles. And here you can see the mesial buccal canals and the distal buccals. And sometimes you could have just 1 canal. So this is a maxillary second molar. This is what we call a conical shaped root. It's just got 1 canal. It's a fused root. Okay, and sometimes you see that. It may have some bifurcations in the apex. We call it apical deltas. And it may have little bifurcations at the apex, but this was a conical shape maxillary second molar with 1 root. Once again, we talked about apical deltas and the apical third of a root. You could have several what we call portals of exit. So instead of having just 1 foramen, you may have several foramina or portals of exit. And this is a maxillary molar in the palatal root. This has a lateral canal going out, and there's a portal of exit there. And if you look closely, there is actually a lesion in that area where that lateral canal goes to and that portal of exit. So we try to see if we could obturate those if possible. sometimes you have some teeth that have really severe dilacerations. And here's a maxillary molar that's got a really, really sharp dilaceration on the mesial buccal root. And that's not really what makes this tooth tough. I mean, we treat teeth that have severe dilacerations, but what makes this tooth really tough to treat is that it's got a crown on it, and it's also very calcified. You know, you can barely see any canal space in this tooth. And this tooth had 4 canals. Here we've got the MB1 and MB2 in that severely dilacerated mesial buccal root. We got the distal buccal and palatal. We were able to go through the crown, use our microscope, try to find those canals using ultrasonic instrumentation. Once we find them, we can open them up, use really small, tiny hand files. Maybe we go with a number 6 file, a number 8 file, a number 10 file, and slowly, carefully debride those canals and open them up, and we can treat those. When it comes to retreating maxillary molars, what we find is a lot of times when we do a retreatment, if there's a lesion on that mesial buccal root, the first thing that we're doing, we're looking for another canal. We know, okay, there's got to be an MD2 in this tooth. So we get our x-ray. We see there's apical periodontitis in that mesial buccal root. So we suspect there's something else. So what do? We take an angle film. And when we take an angle film, we see that there is asymmetry of that gutta percha and that mesial buccal root. And on this radiograph, you could see there is a missed canal. You could actually see the missed canal on a radiograph. So we know what we have to do when we retreat this tooth. So when we went in to retreat it, we actually found 3 canals in the mesial buccal root. This one had an MB1, MB2, and an MB3. So we were able to get in there, clean them out. The MB1 and the MB2, those joined, and the MB3 was a separate canal with a separate foramen. And this was something that, you know, once we get in and we're retreating this tooth, initially I knew I had to find that other canal. There's definitely another canal in the mesial buccal root. But then after we clean everything up, we continue to do some inspection and just very casually just go across the pulpal floor with our endodontic explorer, and we were able to find a 3rd canal in that mesial buccal root. Here's our final obturation. Sometimes you do get some other rare anatomy, previously treated root canal. And, you know, once again, you can see that there's three canals that are treated in this tooth. So whenever I treat an upper molar, if there's only 3 canals, I'm always looking for a 4th canal. Just immediately, it's automatic. We know that's the first thing that we're going for, is to see if we can find a 4th canal. And this tooth actually had a palatal bifurcation. So there was actually, this is a wine type 4 canal configuration in the palatal root, where it started off as 1 canal in the palate and it splits. So if you see on this picture, I'm using a microscope to take this picture. This is looking down into that palatal canal, and I'm probably down about 3 or 4 millimeters into the palatal canal before that canal bifurcates into 2 separate canals. And here you have those 2 separate palatal canals, P1 and P2. Okay, and we did find 2 canals on the mesial buccal root.
Question.
Sure.
What will, when you're looking at that from the palatal, what anatomy on the pulpal floor is maybe hinting to you to say, hey, there may be a 2nd canal on the palatal, in addition to you already thinking that there's a 4th canal somewhere in the mesial?
Correct. All right, that's a good question. So you remember some of those slides that I showed earlier with certain laws that help you determine what to look for and where to look for canals in the pulpal floor. We're looking at the vertices, and then we're also looking at symmetry in our pulpal floor. So, you know, we kind of get an idea that there should be an MB2 in this tooth. If we have the MB1 that's way over to the mesial buccal, okay, there are developmental grooves on the pulpal floor, and we just follow our developmental grooves, and there should be a degree of symmetry in that pulpal floor. So we look for that MB2. As far as those two palatal canals, the palate was it was a pretty wide palatal orifice, canal orifice. So when I say that, it was very oval, very wide. If I go back, let me go back. If you can see this, and you see how wide that palatal canal is, it's more of an oval shape instead of a round circular shape. So what I do, we just go in with an endodontic explorer, or maybe even some small files like a number 10 file, and just do what we call canal inspection. And basically what we're doing is just inspecting the canals, inspecting the anatomy, and using tactile sensation to inspect the anatomy within there. If we're getting a stick that's different from the main orifice or the main canal that we're working in, we get another stick, we explore that, we investigate and see what's going in. And we use our microscope to check for that. Why are we getting a stick that feels different from the main stick that we're getting? Maybe there was some gutta percha that we needed to remove. You know, maybe there's just like a little web or a fin that we have to clean out to open it up. And sometimes you get that. Sometimes you could get failure because, you know, you got the main canal, but there's like a little web or fin or band of tissue that's still remaining, and it hasn't been properly cleaned out and disinfected. So we got to go back in and make sure we get that cleaned out. We don't want to leave any tissue in there. So sometimes do that. And in this case, you know, we may have been thinking, okay, maybe there's a little web or band of tissue we got to get in there and clean out, but it actually turned out to be another canal once we got some instruments down in there. All right. And then that's all part of looking inside these pulp chambers and getting an opportunity to really inspect the pulpal floor in these teeth and see what's there, see what's available. All right. Any other questions? That's a really good question. Any other questions? All right. Perfect. Perfect. All right. All right. Let's move on. So here you have your palatal 1 and your palatal 2. Can you see the MB1 and MB2? Can everybody see those? Okay, I'll move on. Yeah, here's a better view of it. All right, so we've got our MB1 and MB2, and that's over to the right. You've got your palatal 1 and your palatal 2. Okay, and the thing that's key is that these were separate. These have separate apices on the palate. Okay, and then you've got your distal buccal back off to the left. All right, anybody have any questions about maxillary molars? Any questions? Okay. All right, Eric, thank you. All right, everybody's good. All right, so now we're going to move on to mandibular molars. Okay, and mandibular molars have a wide variety of anatomy as well. And there's a lot of studies that came out of. We already know Frank Wine did his studies on mandibular molars, but there were some other studies, Skidmore and Bjornal, and that's in Triple O in 1971. They found that in mandibular first molars, it's rare that they have one canal. You very rarely do you see one canal in mandibular first molars, and it's also rare that you find two canals in mandibular first molars. So 64% of them do have 3 canals. 2 mesial canals and 1 distal. And about 29% of them have 4 canals. All right. So, but once again, that's one of those situations where we really want to look for it. Frank Wine did another study in 1988 with lower second molars, mandibular second molars. He found that about 1.3% have 1 canal, 4% have 2 canals, and majority have 3 canals. That's 81.3%. And then you have 10% that have 4 canals. Now, since these studies have come out, there have been some other studies, and we found some really good information. We found that there are some canals, some mandibular molars that have a middle mesial canal. So that's a 5th canal in mandibular molars. So we'll talk a little bit about some different variations of anatomy in lower molars. But that's just the base. That's a good place to start. Okay. So let's talk about those mesial roots of those lower molars. When we're looking at mesial roots, you could have a type 2 or a type 3 configuration, and those are the most common configurations in mandibular molars. Either they join or they're going to be separate. So a 3rd canal, that's that middle mesial canal that I was telling you about. And we're getting more studies saying that the prevalence of a middle mesial canal is actually a little higher than we always were led to believe. So they're finding that it's about 2.6%. And there are even some more studies that are starting to come out where they're finding that incidence is a little higher. In distal roots, the most common configuration is a type 1. Usually, a lot of times, 62%, there's just one canal in the distal root. But there may be some apical deltas in the apical third of that distal root. But then it's followed by type 2 configuration, which is 14.5%. And then type 4, that's a wine type 4, which is where it starts off as one canal and it bifurcates. And that happens 12% of the time, where it bifurcates on that distal root. All right, so what we just discussed is our basic anatomy in lower molars, but I wanted to spend some time just talking about C-shaped canals. And this was really studied by Cook and Cox, and that's what they're known for. C-shaped canal is common in lower second molars, and you find them in about 8% of the population. But this is what happens when you have anatomical development where the mesial buccal canal joins with a distal canal, and it forms the shape of a letter C, or we call it a crescent. So you got your mesial buccal and your distal buccal, and those join and form the shape of a letter C, and you'll have a separate mesiolingual canal. It's really difficult to diagnose and treat these teeth, but they're usually really, really hot teeth. They're really hard to anesthetize and get them numb. A lot of times we have to go in and do PDL injections or maybe intraosseous injections to get these teeth numb, because they could become very hypersensitive. Because there's so much pulp tissue in these teeth, when you open them up, if it's irreversible pulpitis, these can be very vascular and they can bleed a lot, you know. So we really want to do everything we can to get these teeth numb. And then once we open them up, we got to get all that pulp tissue out. So the challenge is making sure it's cleaned properly, because remember, there's a band of tissue between the mesial buccal and it extends to the distal. So it takes us some time to really get that cleaned up and get that disinfected properly. So here's an example of what a C-shaped canal looks like. And can everybody see where you've got that canal on the left that looks like the letter C, and then you've got a separate canal on the right? That's your mesiolingual canal. But the one that looks like a letter C, that's a mesial buccal that joins with a distal. And this is what it looks like when you fill it up. And that looks like the letter C. So sometimes you have a conical shaped second molar, and it's just one big, large canal shaped like a cone. And cleaning that out can be challenging sometimes, because you have a band of tissue that goes from mesial to distal. Every now and then we'll get a distal dilaceration on that distal root of lower molars. So you'll have a distal root of a lower molar, and just at the apical third, there'll be a dilaceration, a distal dilaceration on those lower molars. Here's the case. There were 4 canals in this tooth, and there's a distal dilaceration. It's important that we could get it in there and clean that out. Sometimes it's a challenge to get around those little curves, especially in the apical third. So we have to put little bends on our files so that we can make sure our files can get around those curves and properly clean out those canals.
Question.
Sure.
You go back to your pre-op of that case. So for GPs, all the GPs that are in here in this room, when we see that, should we run fast or should we tackle?
Well, you know, the American Association of Endodontists has a list, and I could pull that off the website at AAE.org, but they've got a list of criteria of teeth where you want to do a case assessment before you do your root canal treatment. And it's a case assessment to determine the level of difficulty in a case before you treat some of these teeth. And second molars is a difficult tooth to treat. Not only because of the location in the mouth is tough to access it, but because of the degree of anatomical variation in lower molars and upper molars as well. But really in lower molars, you get a lot of degree of anatomical variation in lower second molars. One thing that we do find is that on the mesial root of lower second molars, you do get canals on the mesial where it starts off as 1 canal, and maybe 2 millimeters into the canal orifice, it does bifurcate. And those are tough to get, because sometimes you see them and you just see 1 orifice and you think, okay, maybe there's just 1 canal on the mesial, but you got to get down a little bit further to find that bifurcation on those mesial roots. So with this being said, if there's a sharp dilaceration down there, you know, we usually recommend refer these out, because these aren't easy teeth to treat. What could happen is you get down to the level of that dilaceration, and it's really difficult to get files down any further to clean out that area. So we would recommend referring those out. Okay. All right, so here's our final. Here's a lower molar with 3 distal canals. Okay, and when you look at this on the X-ray, this looks like a pretty straightforward, you know, lower molar. Okay, you can see all the canals, and it looks pretty straightforward. But it's not until we go in there and we treat it, we find that there are actually 3 canals on the distal. You got your distal buccal, your middle distal, and your distal lingual on this tooth. If it's not treated, you know, if you just get the distal buccal and the distal lingual, there's still going to be tissue that's remaining in that middle distal, and that's going to fail. That tooth will fail if it's not treated. Here's just another image where you got your same tooth. You know, you got your mesial buccal and your mesial lingual in there, but then you can see 3 canals on the distal. You see how wide that distal is? We were talking about the laws of symmetry. And if we're looking at symmetry and we're looking at, you know, the pulpal floor and the developmental grooves, that distal buccal canal seems like it's a little off-centered in comparison to the mesial buccal and mesial lingual. It doesn't look like it's centered properly. But distal buccal canals and lower molars can be tricky. A lot of times it's very easy to treat a tooth like this, and you would find the distal lingual and the middle distal, and you think you're done. But sometimes it's good to once you clean up some of these teeth, to go back and just kind of inspect your pulpal floor or the pulp chamber with an endodontic explorer, just to make sure you got everything cleaned out in there. Sometimes you do these and you might see a little bit of pinpoint bleeding, and you're wondering, okay, well, I got 4 canals. What's this pinpoint bleeding? And you go back and you find that there is another canal in there. So it's important to get there and try to investigate and see what's going on and clean these out. All right, here's the final X-ray of that tooth. So when you look at it at a straight-on shot, it just looks like 3 canals. But, you know, you try to get some angled X-rays, and they join apically. but that's what it looks like at an angled x-ray. Here's another angle just to get a little bit more separation. So it's just a wider angle to get a little bit more separation of those three distals. Here's three mesial canals and one distal canal on a lower molar. And we talked about that middle mesial canal on lower molars, and the percentage, they say it's about 3%, but we think that number is a little higher. We're finding more of them now because we have a better armamentarium to help us find these. So we're using microscopes and ultrasonics, and even with CBCTs, it's allowing us to find more of them. This is one. If you look down in here, you see where the mesial buccal is. It actually splits, and then you have a separate mesial lingual. So we call this MB1 and MB2, and then you got your separate mesial lingual. Here's just an increased magnification where we could see where there's a bifurcation of those canals. And this is what it looks like. This is the final x-ray, where you can see they're separate canals. The MB1 and MB2, they actually join, and then you have your mesial lingual. Here's a retreatment of a lower first molar with 4 roots, okay? And that's a separate 4th root, okay? The mesial root usually will be one single mesial root with 2 canals, and this would have a separate 4th root. This was previously treated, and there's a lesion where that 4th root is. Sometimes it's hard to see those. There's a sharp dilaceration on that 4th root. And then we have actually 3 canals. This had a middle mesial. Okay, so we found 3 canals on the mesial, and we got that 4th root. And here we go again, just a final x-ray, 3 canals, and we got these 4 roots. Just another angle. Here's another case with 3 mesial and 2 distal canals, okay? And once again, this has that middle mesial canal we were talking about, the lower molars. This has 2 mesial and 3 distal canals. And this is, if you look at the distal, this one has a bifurcation as you go down into that canal. All right, so in conclusion, root canals are made up of complex systems, and we talked about that. And we know it's not just single lines or single cones where you start from one end and you get a single cone. You got isthmuses, apical deltas, fins, webs, and a lot of them, they interconnect and they anastomose. So it's important to have good knowledge of that complex and the laws of floor anatomy. You want to access that chamber, locate those canals, try to avoid perforation, always have a good sense of where you are. And if you're not sure if you're going to perforate, if you're trying to find those canals, you're going in with the burr, it always helps to go back and take an x-ray and see where you are. You could put something in the canal where you are to see, to get a landmark, just to see where you are, and then go back. And then, of course, if you know your root canal anatomy and you know what you're looking for when you go in, it's going to help preserve tooth structure. So you're not gouging out the inside of the tooth looking for canals. You have a sense of where they are. Radiographs and CBCT can be helpful, but nothing replaces just really inspecting the pulp chamber. And I was telling you before, sometimes I go in, I'll do a root canal, and I'll find 3 canals. And I say, you know what, let me go back, take another look. I'm getting ready to fill, and everything's cleaned out. And I'll go back and I'll take another look, and I find a 4th canal. So inspection, you constantly, while you're working, as you're working, it's always good to constantly inspect and re-inspect your pulp chamber. I can't really stress enough the importance of magnification and illumination. a lot of times I do treatment on these teeth, and I always ask myself, what did people do before we had microscopes? It's just really tough to find these without the aid of a microscope. And loupes are good, you know, but it's just not going to give you the degree of magnification and illumination that a microscope would give. But definitely, if you don't have a scope, I would strongly recommend using loupes, and make sure you have good illumination. The experience of the clinician is very, very helpful. I mean, there's nothing that beats experience. The more you do, the better you get, just like anything else. And of course, if you're not sure, and if you have some case that has a really high level of difficulty, there's nothing wrong. There's nothing wrong with having to refer a case to an endodontist. I mean, that's why we have specialists. That's what we're here for, to help. So, you know, if you have any doubt about a case, you know, keep the patient in mind, and, you know, you want to have the outcome that's going to be most favorable for that patient. And then on top of that, you want to consider the crown or the final restoration that you're going to place on that tooth. You want it to have a high level of success. So there's nothing wrong with having to refer a case to an endodontist if you need to. So don't be afraid to face your challenges head on. Stay out of trouble. Okay, team up with someone who's got your back. In residency, you work hard, but take time to relax. Smile. Reach for new heights. And impossible is nothing. Dream big. I want to thank you so much, okay? Please feel free to call me if you have any questions. This is our website for our location. We've got 5 locations, 5 endodontic locations in the Maryland and DC location, DC area. You know, if anybody's interested in endo, please, by all means, give us a call. We really like to help people and mentor, you know, potential residents who may be interested in going into an endodontic career.